we'll end with our last podium presentation after a long day of informative, scientific, and heavy scientific meeting. We are starting with the first podium presentation. And dear all guest speakers, please present your name, your title, your topics, and the institution. We'll start with the first presentation with Dr. Riham. The floor is open for you.
Good evening, everyone, and thank you for staying until the end. So my name is Riham Hussein. I am AGU graduate, now still GP. Okay. My presentation will be about the prevalence and the correlates of female sexual dysfunction, a pilot study from Bahrain. My colleagues in the research are Dr. Lulwa Salah, Dr. Nof Bahzad, Dr. Ahmed Jaradat, Dr. Naima Mahmoud, and Professor Diyares. So just to start with, this is the first type of a study held in Bahrain as in a hospital-based.
What is your position?
I'm GP,
okay.
General Practitioner. So, as introduction, the epidemiological research in the field of female sexual dysfunction is limited to only the diagnostic dilemma. That's because of the complexity of the female sexual response. As yet, there are also no data in the literature from our community regarding the female sexual dysfunction. The voice is clear, or is it clear? Okay. So the objectives of our research is to determine the prevalence and socio-medical correlates of female sexual dysfunction in Bahrain and assess the consequences in the affected women in order to investigate the public health burden of the disease and increase the awareness among the healthcare providers. So regarding our methodology, this is a hospital-based research. It is held in two centers, Salmania Medical Complex and King Hamad University Hospital. It's a cross-sectional study, was conducted in Bahrain with a sample size of 255 of married and non-pregnant women aged between 18 and 55 years who just presented to the ambulatory clinic with a gynecological complaint which is not related to sexual dysfunction. The participants were interviewed using a validated female sexual function index questionnaire. So the demographic, obstetric, medical, and socioeconomic data were collected, and a cut point for this questionnaire FI score of less than 26.5 out of the maximum 36 was used to define the presence of the female sexual dysfunction in our study. So coming to the results. The results were surprisingly, the overall prevalence of female sexual dysfunction was 55.7%. with a sample of 142. Okay. The majority of the study subjects were Bahraini, representing 11.5%. There are also other nations, but the difference of population characteristic of this population was not significant. Coming to the results, I prefer to present with the other table first. So as you can see, we check the correlate between the association between the sexual dysfunction and gynecological complaint. As you can see, the primary complaint was chronic pelvic pain, dysmenorrhea, and severe premenstrual symptoms were representing the most of the symptoms, around 60%. The significant result, I mean the significant association was with the abnormal uterine bleeding and vaginitis with a significant p-value. So this is the number one result significant in our study. Coming to the other one, the correlation with the medical problems and the use of medications. We found that the use of hypertensive medication is associated with a female sexual dysfunction. The other parameters, the obesity, income, smoking, and age, are not significant in the female sexual dysfunction. And the most significant domains, component, effect in the female sexual dysfunction in our score, FSFI score, was pain, satisfaction, lubrication, orgasm, desire, and arousal in order. So in conclusion, female sexual dysfunction is a highly prevalent condition in married women in Bahrain with a significant adverse impact on their quality of life. And this deserves more attention in the public health agenda and should be the priority in women health care providers. Thank you.
Thank you, Rehan, for presenting an interesting article, but I know that one of the main reasons of this dysfunction, sexual dysfunction, is psychological factor. Did you study that?
The psychological impact?
Yeah.
Of course, in our study, we didn't specify and use in this aspect as it is, specifically. So we didn't study the psychological aspect. And doctor, I want to add that we used an international score, and FSIF, which is the psychological aspect is not included in this score. So we based our study on this international score.
But did you compare it with other study has been done regarding this kind of presentation, this kind of study?
Sorry, doctor.
Did you compare your study with other international studies?
In the literature, there are not enough studies examining that in the region, in Bahrain itself. So in Bahrain, we couldn't find a previous study to compare with. So this is the first study in Bahrain.
The floor is open for one question only.
I just have a comment.
Okay, please.
Regarding this study, actually the selected populations, actually patient who doesn't have complaint of sexual dysfunctions. Therefore, we didn't measure their psychological impact. This is our initial one. Second, after we started this study, there has been published articles about sexual dysfunction in Bahrain, been published recently, I think 2018, by Dr. Ilham Atallah. And that was the selection of population is actually patients who came with main complaint of sexual dysfunction. So that was the comparison of these two groups is completely different. So we have here unselected populations without any sexual dysfunctions. They come routinely for a gynae problems. This is a sort of screening, sort of to find the prevalence of sexual dysfunction in that Bahrain populations.
Thank you, Dr. Naima. Yeah, thank you, Doctora.
Okay, thank you.
The second speaker, please.
Good evening, ladies and gentlemen. My name is Fatma Nasser Al-Fayez. I am a Year 6 medical student from Arabian Gulf University. I'm really glad to have this opportunity, and I feel pleasured to present in front of you all. I would like also to thank all of my colleagues who have worked with me in this research. It's an experience and severity of Premenstrual Syndrome among GCC sample using a newly developed Arabic language scale, a meta-analysis. So Premenstrual Syndrome is a combination of physical, psychological, and behavioral symptoms. It's not caused by an organic disease, which regularly recur during the same phase of the menstrual cycle and significantly regress or disappear during the rest of the cycle. Symptoms, as I mentioned, are mainly physical, psychological, and behavioral. And from the physical, we have breast tenderness and bloating. From psychological, we have mood swings, irritability, and from the impairment of functioning, we have like low cognitive performance and suicidal attempts. Majority of women from previous studies are from 80% are experiencing mild to moderate premenstrual symptoms, and only 3 to 8% have experienced severe symptom, which is called premenstrual dysphoric disorder. Premenstrual dysphoric disorder wasn't added to the DSM-5 criteria until recently, and from previous epidemiological studies, we can conclude that all of the epidemiological studies regarding PMS were done on Western subjects, and the only reason why is that we don't have an Arabic language scale, and thankfully in 2013, Dr. Haifa Al-Gahtani have developed this Arabic language scale, having a 4-point Likert-like scale with the degrees of severity, and 23 items that are divided into 3 domains: physical, psychological, and impairment of functioning. They only take 5 to 7 minutes to be administered to patients, and it has a high reliability of chromback of more than 0.95%. So we used 3 cross-sectional studies, one done in KSA with a sample size of 350, one in Bahrain with a sample size of 250, and one in UAE with a sample size of 300. The women in these 3 studies aged 15 and above, and the ethical approval and informed consent were sought from respective authorities, combined with using fixed effect meta-analysis. So you can see from all the 3 studies that the mild to moderate symptoms represent the majority of the experience, of the PMS experience, compared to the severe symptoms. You can see it in KSA, Bahrain, and in UAE. So the prevalence of psychological symptoms in KSA was 97.1%, in Bahrain it was 99.8%, and in UAE was 99.3%, with overall estimate of 99.4%. And the I-square, which is a measure of homogeneity, so when the results are approximate to 0, they are more homogeneous, and when they are approximate to 100, they are more heterogeneous. You can see here that the I-square was 0, which means that the results are homogeneous. The prevalence of physical symptoms in KSA was 97.8%, in Bahrain it was 99.8%, and in UAE it was 77.7%, with overall estimate of 99.1%, and the I-square was 0, which means the results are homogeneous. The prevalence of functional impairment in KSA was 67.3%, in Bahrain it was 68%, and in UAE it was 77.7%, with overall estimate of 72%, with I-square of 0%, which means the results are homogeneous. So the overall BMS experience in KSA was 98.9%, in Bahrain it was 99%, and in UAE it was 99.8%, with overall estimate of 99.7%. And the results are homogeneous since the I-square is 0. So in conclusion, the overall BMS experience was 99.7%, with the majority was psychological symptoms with overall estimate of 99.4%, and physical symptoms with overall estimate of 99.1%, while interference with functioning was minimal, only 72%. We have to repeat the study and include and extend it to other Arab countries, including other GCC countries like Qatar, Oman, and Kuwait. And we would like to study also the influence of diet and exercise and smoking. Also worth mentioning that we have other 2 studies. One will be published in Jordan, one will be published in US, not published yet, using the Arabic BMS scale. And once they are published, we will include them and make the meta-analysis to get a full result using the Arabic BMS scale. That's it. Thank you. Any questions?
See, we used to read that there is an association of premenstrual tension with the future development of endometriosis. Did you find anything like this link in the literature?
Can you repeat the question? I can't hear you.
Those ladies who suffer from premenstrual tension, they are future candidates for endometriosis.
Okay.
Is there any link?
from previous literatures, no, we didn't find this, but I will check.
You can
Again.
add it to what you mentioned in the last part, that you have to study regarding the diet, the smoking, and even the socio-economic factor, and with the endometriosis, other medical factors.
Yeah, inshallah. Thank you.
Floor is open for one question, please. Comment or question? Okay.
Did you validate this index against other indices for measurement of premenstrual syndrome? Did you validate your instrument against other indices used before to measure premenstrual syndrome?
The previous literatures, you mean?
No, other instruments. Did you validate this questionnaire, whatever? Did you do a validity study? Validity study for this questionnaire?
The Cronbach, yeah. Cronbach reliability.
Cronbach is intercoefficient correlation, something different.
Okay.
Did you validate this against previous instruments used to measure premenstrual syndrome or not?
This wasn't my cooperation in the research, because Dr. Haytham Al-Jahrami is the meta-analysis boss.
Second thing, and advice to you, this is not a meta-analysis, it's called pooled results. You pool from 4 studies, and you pool the results at the end. It's not a meta-analysis. Meta-analysis is completely different.
Okay.
When you analyze studies, different studies from the literature. So meta-analysis is a bit of, I think you have to define it clearly. It's called pooled results of 4 studies.
Okay, because the meta-analysis was done from Dr. Haytham.
Meta-analysis means getting the pooled results, because you have 4 studies, you want to get the final results.
Okay.
Meta-analysis is completely different.
Okay.
You analyze studies already published in the literature.
We are ready for the third speaker.
I'm Dr. Kamal Rajah, consultant of Hopes and Gynae IVF in Al Baraka Fertility Hospital. I'm lecturer of Hopes and Gynae IVF at Azhar University, Faculty of Medicine, Egypt. So first of all, I'd like to express all my grateful thanks and appreciation for the organizing committee who give me this chance to be now with you in your hands and going through this very important topic, which is entitled PRP and Recurrent Implantation Failure, Hope or Hype. Let me first to share with you this short story before I go through this one. Ken Yamakan. Once upon a time, Mrs. H came to our clinic. She is 34 years old, nulli gravida with primary infertility, 14 years duration, with history of recurrent implantation failure on top of 5 failed exit trial. She asked me apparently a simple question. Doctor, why did my IVF cycle fail? This is apparently simple question. After long chat, she left the clinic. I took a deep breath and long time thinking about this difficult situation. IVF failure caused a lot of distress for both patient and doctor as well. Lots of questions, and actually there is no clear answers. So this problem repeats itself and is frequently seen in most of the IVF units. We, as doctors, should do our best putting an end to such an agony for those patients. Because the patient blames themselves. Did the IVF cycle fail because I did something wrong? Exercise, diet, stress? Is my body rejecting these embryos? Because the patient perspective, according to the patient perspective, egg plus sperm equal to the baby. Please, at this situation, don't shun your patient. After IVF failure, patients are very vulnerable. Can be angry with the doctor, blame you for the failure. Doctor don't want to talk to the patient when the cycle fails. Please, don't abandon your patient. They need you the most at this time. It's better to go for analysis. What went right? What went wrong? What we have learned? Do we need to change anything in the future, the next time? And what we can change? Because I believe that success always coming through the failure. What went wrong? The follicle didn't develop as expected, or the oocyte sperm quality was not so good, the fertilization rate was so suboptimal, the embryo quality or morphology was not the good, the embryo transfer was difficult, or the endometrium development was suboptimal. The endometrial function and the endometrial receptivity have been accepted to be major limiting factor in establishment of the pregnancy. We have improved almost all aspects of IVF, like ovarian stimulation, embryo culture, and transfer, but still the pregnancy rate is not satisfactory. We believe that the bottleneck is the process of the implantation. So what is implantation? The implantation, this is the most vital, and unfortunately, this is the least understood part of the reproduction. So it's a matter of seeds and soil. So we have to select the best seeds, we have to prepare the soil, and we have to plant at the proper time. Recurrent implantation failure is really one of the nightmares in the reproductive medicine. And despite several strategies that have been described for the management, still there is no universal agreement yet. Recently, intrauterine infusion of the PRP, or platelet-rich plasma, is described to promote the endometrial growth and receptivity. The PRP has been investigated as a therapeutic approach for several medical disorders in rheumatology, dermatology, but still its use in IVF is so limited. So we designed this study to evaluate the effectiveness of the endometrial perfusion of the PRP in improvement of the pregnancy rate in recurrent implantation failure patients. This is our clinical trial registration. This is our unique ID of the registration number in the clinical trial, US. This is a prospective randomized controlled study for 150 infertile women with history of recurrent implantation failure, all recruited from our outpatient clinical Baraka Fertility Hospital. After giving their consent, with this is the inclusion criteria: age below 40 years, the body mass index below 30, divided in two comparable groups. All participants underwent an antagonist protocol. In the study group, the intrauterine infusion of the BRB was performed 48 hours before the blastocyst transfer, and 12 days later, we'll check the pregnancy test. This is the demographic criteria between the both groups, study and the control group, and we can notice that there is no statistically significant difference between both groups regarding the age, body mass index, infertility duration, cause of infertility, or AMH. And also, there is no statistically significant difference between both groups regarding the characteristic of the IVF cycle. And this is one of the important factors to eliminate any bias between the both groups. Okay, and finally, this is our results. Out of 75 participants in each group, 32 got pregnant, which actually 43% in the study group who received the BRP, compared to 11 only, almost 15% in the control group. And we can notice here, this is highly significant difference between the both groups regarding the pregnancy test. So, there are some points which I can explain why this is our study. This is the main point of strength of our study. This is by far the first study discussing this topic here in Bahrain, as our hospital is the leader IVF center here in Bahrain. The low risk of bias between the study and the control group, as both of them were statistically comparable. We exclude those patients with hematological, immunological, hormonal disorders, chromosomal or genetic abnormalities, as confirmed by uterine abnormalities, also as confirmed by ultrasound and HSG, to limit the additional factor that may affect the result of our study. All the blastocyst transfer were performed under ultrasound guidance by only one expert gynecologist, the consistency between our result and those of the previous literatures. Of course, there are some limitations in our study as we are living here in a small country. So the sample size we may need to increase in the future coming clinical trials. Also, at the same time of the transfer, we didn't select those embryos based on genetic basis, because actually are not doing the BGT as a routine in our practice. So we select the embryos phenotypically. In conclusion, or take-home message, after an IVF failure, please show some sympathy to your patient. Be honest. Truth with compassion. Be kind. Your patients are really emotionally vulnerable at this time. IVF often is their last hope. When this fails, it is the last straw. They feel they are useless. Please help them to cope with this rough patch. It's better to tell the truth. Often the truthful answer is, actually, we don't know why this cycle failed. Human reproduction is not an efficient enterprise. Please, not an answer patients want to hear, not an answer doctors want to give. Because always remember this, wrong is wrong, even if everyone is doing it, and right is right, even if you are the only one who is doing it. The recurrent implantation failure is hard to be managed, and if all available treatment fail, the endometrial PRP may add value. According to our study, PRP significantly improved the pregnancy rate and may be a new hope in recurrent implantation failure patients. PRP can stimulate proliferation and regeneration with large amount of the growth factor and cytokines that may improve the endometrial receptivity and implantation. PRP is collected from the autologous blood sample, so in comparison to the clone-stimulating factor or the growth factor, PRP is more accessible and affordable. And sure, there is still a big gap in knowledge. There is not only a gap in mapping the entire process, but we believe that there is also a gap in translating this knowledge into the clinical practice. And sure, this is our fate, and we have to face. If life was easy, where would all the adventures be? Never say I can't, always say I can. And at the end, I have to express my grateful thanks and appreciation for all my staff members and colleagues who are standing beyond this work, working in lovely environment under supervision and the motivation of this great man. This is Dr. Ahmed Barakat. Thanks, everybody. Thank you so much. If any questions?
Beautiful presentation, very informative. And you know that there is still a gap between this knowledge, and I'm sure you young doctors will fill it up.
Okay. Any question?
Floor is open for one question. Is there any comparative study? Did you notice this in the previous study regarding?
Yes, all the studies before, 3 or 4 studies done before, and concluded the same result we have as well.
But the first study was showing in BRB in 2015 with the Japanese group, they studied the BRB for the patient who have thin endometrium.
Yes, this is another topic. That's why we are coming in the clinical trials. We are going for the refractory endometrium or thin endometrium. Okay,
how you define in your study recurrent implantation failure? What is your selective criteria?
Yes, from the clinical point of view, it's worthy to be noted. There is 2 types of the recurrent implantation failure. Either who didn't have any evidence of HCG production, okay, it's negative from the start, or those patients who can't go beyond the clinical fetal heart rate.
No, I meant, what did you select for recurrent implantation? What
Actually,
is your criteria?
So far.
There is 2 definitions for recurrent implantation failure.
There is not only 1, 2, or 3 or more definition. All of us know very well that there is no universal agreement about the definition of recurrent implantation failure.
Okay.
All the literature can define how many, 2 times, 3 times, 4 times, we don't know actually. Even though they are different in what's meant by the negative or clinical pregnancy rate. Either it is fetal heart rate or only chemical by positive beta HCG.
And what was your primary outcome?
This is the primary outcome. We didn't go for the clinic. That's why we are going for the clinical. In the further clinical trial, we'll go for the refractory endometrium, the thin endometrium, and we are going beyond the clinical pregnancy rate.
Thank you. Any question, Dr. Naima? Yes.
Regarding your study, can I just have the tables again for the result? Can I see the table for the result again, please?
Yes, sure. Still, it's gone.
Okay. Regarding that one, when you started, how long does the study have taken for you? What is the end outcome? What was the end outcome? Is it a pregnancy or take-home baby?
No, just pregnancy test.
Pregnancy. So it doesn't matter if it is biochemical pregnancy or not?
That's why this is the same question, just now asked. We didn't go beyond this one.
Okay.
Okay. This is in the future, our coming clinical trials.
Okay.
This is the same question, actually. This is
okay. When did you start? Did you have the intention to treat as a primary, as one of the requests? Intention to treat, and when you obtain your ethical approvals, did you had any ethical approvals actually been obtained?
We have our own ethical committee of approval, and also we have this one, the approval from the clinicaltrial.gov.
Okay.
It's already registered. I already showed up this slide for the presentation.
Thank you, Dr. Kamal.
Yes, that's it.
Okay, so my question was, do you have that intention to treat as one of the primary prerequisites when you started randomizations?
Randomization, yes.
Did you?
No, this is randomized controlled trials.
Yes.
Okay, but we already eliminate all the bias factors. So you can notice this one also. And in this table, you can notice this is the study between the demographic criteria of the study control and the study group. And you can see this is the p-value. There is no significant difference between the both groups.
Okay, yes.
Okay, regarding the demographic criteria or regarding the characteristics of the IVF cycle itself.
Yeah, because what I can see from your result, that you have very high significant
Yes.
result.
But we can't conclude this one because actually this is a small sample size. It's only
Yeah.
150, so it's divided 75, 75.
Okay.
In the
But
future, we are going to increase the sample size.
usually when you have a study, even a randomized studies, if you have that sort of effect, which is the very high efficacy of the treatment, it sometimes doesn't look ethical to withdraw the other groups from that interventions.
Yes.
That's what I meant by intention to treat. Because sometimes you just end that studies and they say, because our values was very high and it is unethical to withdraw the other groups from the intervention that you are planning to do. You either withhold the studies.
We concluded the result as it is. Okay?
Sorry?
We concluded the result. You can see this one and this one. This is highly significant difference. We can see the difference between this is 43% in the study group who received this autologous PRP in comparison to only 15% in the control group. So actually this is a surprise for us. That's why we need to more validate this study in the future coming clinical trials. And this is only for the, this is chemical pregnancy rate 12 days after the pregnancy. So we can go for further step. We can go for the clinical pregnancy rate or take home baby, as you mentioned, and we need to increase also the sample size. So we can conclude it's effective or not. But so far, according to our study, yes, it's conclusive, like this. So in the future coming, we believe that it's a matter, as I mentioned, it's a matter of seeds and soil. So we have to, I believe that this crosstalk between the endometrium and the development.
Yeah, I understand all this sort of things.
So what is beyond this theory, what the mechanism of action, let's say, this is, we believe that this is a crosstalk between the endometrium and the developing embryo. It's mediated through some growth factors, okay? Like epidermal growth factor, vascular endothelial growth factor, insulin-like growth factor, and cytokines, interleukin-1, interleukin, like this.
Okay. Did you had any adverse effect of using?
No, never. Because it's autologous already. It's from the same patient and to the same patient.
And
So
most of this cycle are fresh or fresh cycle or frozen cycle?
this is
The transfer.
no, all antagonist cycles, the same cycle
Fresh
with it,
cycle.
yes.
Okay, thank you. Thank you, Dr. Kamal.
Yes, okay.
Now the fourth
Any more questions?
The last speaker.
Assalamu alaikum. Masakum Allah bil khair. My name is Fatma Rahal. I'm a 7th year medical student from Kuwait University, Faculty of Medicine. I'm very happy and honored to be here with you today. And I know by now most of you are already tired, so I hope that you are going to enjoy the last few minutes with me. So let's get into the topic of my research, which is a life shaped by pain, dysmenorrhea among female high school students and its associated factors in Kuwait. So by seeing the topic, you can get an idea about the objectives of our study. So we wanted to estimate the prevalence of dysmenorrhea among the 12th grade public high school female students, and also know its impact on the school absenteeism, missing school days, missing some exams. We also wanted to investigate the factors that are associated with dysmenorrhea. So before we dig deep into the results that we had from Kuwait, let's see some results from the worldwide in general. So the prevalence worldwide of dysmenorrhea is usually ranges from 45 to 95% among menstruating women worldwide, and almost all epidemiological studies studied some uncertain risk factors that might be associated with dysmenorrhea. However, they are not 100% associated with dysmenorrhea. Some of those include smoking, type of diet, physical activity, and BMI, weekly consumption of both fast food and fried food, and then lastly, weekly consumption of energy drinks, coffee, tea, and carbonated drinks. So now to our research. So we have structured a questionnaire in which the key question in our research was, during the last year, did you have pain with your menstrual period or not? We did that. You might be wondering, why did we do that? Because actually, after an extensive literature review, we were not able to find one validated, standardized, or proper questionnaire that can assess menstrual pain among female high school students or any female patients. So the students were asked if they have had pain in the last year, and the answers would be either yes always, yes often, yes sometimes, yes rarely, or never. And then if the students answered yes always, often, sometimes, we would categorize those answers under the group of yes dysmenorrhea. If she answered yes rarely or no, she would be considered to have no dysmenorrhea. So now if the girl said yes for pain, yes, I have pain, how can we assess that pain? Well, we use something called visual analog scale. With a 10 centimeter line, we gave them pencils and asked them to mark the worst possible pain they have had during the last year. So it would be either mild pain, moderate pain, or severe pain. So one end would represent no pain, and then the other end would represent the worst possible pain the girl had during the last year. So now to the results. Out of 787 students, 766 agreed to participate, excluding 3 students who haven't reached menarche yet. So out of those, 763 participants agreed to participate. Out of those, 653 students had dysmenorrhea. And believe it or not, out of those, 20% had mild dysmenorrhea, 30% had severe dysmenorrhea, and 50% had moderate dysmenorrhea. And this is a huge number. So we also repeated the analysis after we got those results. We wanted to see those who have answered with yes rarely. We wanted to see, will there be a difference in the prevalence of dysmenorrhea? So after the prevalence was 85.6%, after taking into calculation those who said yes rarely, the prevalence has jumped from 86 to 92%. So can you imagine how many of those girls might actually be having endometriosis or other pathological gynecological conditions besides endometriosis? Even though dysmenorrhea is not a life-threatening condition, it can cause a substantial burden. It can cause a substantial impact on the individual and communities. So 14% no dysmenorrhea and 85% had dysmenorrhea. Now, to the results of our study, of those students with dysmenorrhea, 58% missed at least one school day, and then around 14% of the participants with dysmenorrhea missed at least one exam during the past academic year. Of the participants, also 26% with dysmenorrhea have visited a public or a private clinic. Around 4% of the participants were hospitalized and admitted to the hospital because of dysmenorrhea. And one girl I have interviewed during this study actually told me that she misses 3 to 5 days each month in her school. So if you want to calculate that, this might be around 25% to 30 days during a whole academic year. Can you imagine the impact of dysmenorrhea on this girl's studies and life? Now to the fun part, the association between dysmenorrhea and potential risk factors. So we have found around 4 factors that can be possibly associated with dysmenorrhea. Some of them goes with the literature and some of them do not. So the first one is the onset of puberty. So it was significantly associated with dysmenorrhea, and this actually is similar to that reported in the literature. This can be attributed to the fact that early exposure to prostaglandins, early menarche means early exposure and longer exposure to prostaglandins, which means higher chance of having dysmenorrhea. Now, the second factor is the regularity of menstrual period. So you might think that if you have regular period, you might be having less chances to have dysmenorrhea, right? However, surprisingly, in our research, the association between the regularity of menstrual period and dysmenorrhea was negative. So some studies found the opposite, some studies simply found no association. So this is just a finding. No robust scientific evidence and literature exists regarding the negative association. So what about the third factor, the flow of menstrual period? So we relied on the students reporting their flow of menstrual period, so it would be either mild, moderate, or heavy with clots. So it was also positively associated, and the greater the menstrual flow of blood, the more likely you will have dysmenorrhea. And then for the last factor is weekly drinking of coffee. So 4 cups or more during 1 week means having more chances to have menstrual pain. It was positively, significantly associated with dysmenorrhea. And in fact, it is the only modifiable risk factor in this study. You can't control the other. You can't control the flow of menstrual period or your age of menarche, but you can control the consumption of coffee. So if we want to recommend, we might advise students or female patients to reduce the amount of caffeine intake in order to make their menstrual pain better. So because of caffeine, which is the main component of coffee, it can constrict your blood vessels, and then when it constricts the blood vessels, it reduces the flow to the uterus, which can increase the degree of pain. So finally, the conclusion and recommendations. You can now know the high number of students in Kuwait who have dysmenorrhea. It is highly prevalent in Kuwait, so we can almost say that 9 out of 10 students experience dysmenorrhea monthly in Kuwait and also other countries worldwide. So many of them are visiting hospitals and missing school and exams. And because almost all the schools in Kuwait have a clinic that has 1 nurse or 2. We can utilize that in order to train nurses and tell them how to reassure and how to manage. Not also this, but also how to refer those cases of suspected secondary dysmenorrhea, because we have primary dysmenorrhea and we have secondary dysmenorrhea. So if the nurse suspects one student of having secondary dysmenorrhea, why not refer her to a tertiary hospital? Thank you.
Can I ask you a question?
Yeah, sure.
Thank you for a very nice presentation.
Thank you.
What we used to read when we were students is a dysmenoric mother produces a dysmenoric daughter.
Is that dysmenorrhea what? Sorry?
Yeah, if the mother is having dysmenorrhea, her daughter is chances
Is more
of
likely
having
to have
dysmenorrhea
dysmenorrhea,
is
yes.
very high.
Yes.
Since in your presentation the dysmenorrhea percentage is so high,
Yes.
I think we have to study the family history. If the mother is having dysmenorrhea, maybe the daughter will have.
Yes, we have actually asked this question in our study. If the mother had similar complaint, if the girl reported some menstrual pain, we would ask her, did your mother also suffer from any gynecological conditions such as adenomyosis, endometriosis, or just primary dysmenorrhea?
But how did you scale the pain of dysmenorrhea?
Yeah, we used
Because you mentioned mild, moderate, severe.
Yeah, so no study worldwide has specified how did they rate the degree of pain. This is why we have decided to use the visual analog scale, which is used in some studies to rate the pain. So from 5 to 44 will be mild, and then 44 to 75 would be moderate, and then severe.
Any question, please?
Yes.
Yes. Microphone, please.
Yeah. Yes. Yeah.
We cannot hear you, Doctora.
Sorry, actually, what I wanted to say was that one of the modifiable factors is menstrual flow.
Yeah.
Okay, we know that backflow of blood is one of the leading cause of endometriosis, at least of all the theories. And if a girl is getting a lot of heavy bleeding and clots, the uterus is going to contract vigorously to throw those clots out. And that will contribute to her dysmenorrhea. So definitely the flow of blood, and we have several agents which can alter the flow of blood even if there are no other pathologies. And we of course have entities like dysfunctional uterine bleeding where we don't find causes and we can alter. So it is a modifiable factor.
Yeah.
In fact, I think you can bring down the endometriosis incidence. The other thing I want to comment on is I think there's a cultural factor here. If the dysmenorrhea rate is 85%, maybe there's a perception in these girls' heads that they're supposed to get painful periods. Because I don't know, I have not seen this kind of incidents. What do you think of that? Do you think we have such a huge number of teenagers walking in or telling us, maybe they tell their mothers, the mothers do tend to ignore these girls.
Higher socioeconomic status.
Yeah.
It's a disease linked also to the higher socioeconomic group.
So even though the prevalence was high in our study, just for your information, it was also similar to that results from high-income countries such as Canada. Canada has a prevalence of around 65%. Iran has a prevalence of 98%. Saudi Arabia has a prevalence of 94%. So I agree with you. It might be really very highly prevalent and something that doesn't make sense, but
because
for me,
the
yeah.
way, if you say that, I will say this is a normal feature.
Yeah.
Only 15% don't get
Yeah.
pain and everybody else gets pain.
Yeah.
It means that we have to rethink our criteria of dysmenorrhea.
Yeah.
I mean, 85% of the population means it's normal.
Yes. Some have primary dysmenorrhea and secondary dysmenorrhea. And one of the problems we faced in our study is that there was no one clear definition of dysmenorrhea. So if you don't have a clear definition of dysmenorrhea, you can't tell what is really dysmenorrhea and what is not, even for the students when they get asked about dysmenorrhea. They can't tell you if they really had dysmenorrhea or not.
As a previous, you know, there is something called primary and secondary dysmenorrhea. It should be even part from your presentation.
Yeah.
Thank you very much,
Thank you.
Doctora, and good evening for everyone.
Congestive dysmenorrhea.
Thank you.
Thank you.